Tracheoesophageal puncture incorporating a valved silicone voice prosthesis has evolved worldwide as an established method of post-laryngectomy voice restoration since its introduction by Singer and Blum in 1980. Our 14-year experience with more than 1,200 primary and secondary voice restorations has resulted in improved surgical techniques and a better appreciation of the influence of the pharynx in the acquisition of alaryngeal voice. Of parallel importance has been the introduction of improved voice prosthesis designs, tracheostoma valves for finger-free speech, and an airway humidification system. A small but important number of factors are considered in selecting appropriate candidates for secondary tracheoesophageal puncture. Most of these criteria are unknown at the time of laryngectomy and consequently not applicable to the primary voice restoration decision process. Candidates for secondary tracheoesophageal puncture should have a 6-week recovery from previous laryngectomy or postoperative radiation therapy. A minimal tracheostomal diameter of 2 cm is required to receive and accommodate a voice prosthesis without potential airway compromise. Microstoma is managed prior to tracheoesophageal puncture by either surgical revision or use of a dilating soft silicone laryngectomy tube. The surgeon and speech therapist have a responsibility to thoroughly inform the patient and family about tracheoesophageal puncture as well as other appropriate alaryngeal speech options. Candidates should be self-motivated as well as physically and mentally capable of participating in a program of tracheoesophageal voice restoration. The capacity for self-care of the stoma and a prosthesis is a requisite and should not be relegated to a family member, despite the availability of voice prostheses requiring less frequent maintenance. A transnasal esophageal insufflation test provides a subjective method for assessing pharyngeal muscle response to esophageal distension. 4 distinctly different responses have been described and can be clearly visualized with the test procedure done under fluoroscopy. The first of these is spasm, characterized by substantial upper esophageal distension, gastric filling, and reflex contraction of the inferior and middle constrictor muscles. This is visualized as a hypopharyngeal bar simultaneous with essentially complete aphonia. Keep going, push, that's it. You take a breath and try a long, steady ah. Okay, breath in, try it again. Hard. Okay. Okay. Take a breath in. Try to count loud to 10. Hypertonicity is characterized by a lesser degree of pharyngeal muscle contraction, effortful interrupted phonation, and reduced but obvious esophageal distension. These 2 negative responses are observed in from 20 to 40% of laryngectomized patients and will require unilateral myotomy of the pharyngeal constrictor muscles to achieve fluent, effortless alaryngeal phonation. Patients with normal tonicity demonstrate sufficient relaxation of the pharyngeal constrictor muscles during esophageal insufflation to produce sustained vowel phonation of 8 seconds duration or longer, and to fluently count from 1 to 15 without interruption or effort. Esophageal distension is visibly absent on fluoroscopy.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. The final category of response is characterized by reduced or absent pharyngeal muscle tone during esophageal insufflation and is designated as hypotonicity. The voice is fluent and effortless, but inadequately loud and often whisper-like in quality. There are 3 basic types of Blum-Singer voice prostheses: the duckbill
type voice prosthesis is a 16 French silicone tube with a one-way slit valve in its tip. It can be removed and reinserted by the patient. The low pressure type voice prosthesis is available in 16 French and 20 French diameters and has a one-way flap valve in its tip. It can be removed and reinserted by the patient using the gel cap insertion system. The third type is the indwelling low pressure voice prosthesis, which is a non-patient removable extended wear device described in the following sequence. The indwelling low pressure voice prosthesis is a 20 French device manufactured in translucent medical grade silicone. At either end of the device is a large and thick retention collar. The esophageal retention collar has a radio-opaque ring incorporated in the edge of the collar for confirmation of collar positioning within the esophageal lumen.